Hello, everybody. Welcome to another episode of the Healthtech Pigeon podcast. With me today, I have Huw from the SomX team, and delighted to say on what he is describing as a flyby relevant to the Healthtech Pigeon podcast, of course, is our friend Liam Cahil. Liam is having an emergency visit to the Pigeon podcast because obviously overnight the Lord Darzi report has been written. Liam looks pretty fresh given that it's 163 pages, clearly stayed up at least some of the night reading it. But Liam, welcome to the Healthtech podcast, or Healthtech Pigeon podcast, I should say. How are you doing?
I'm all right, thanks. I just got really early. I wasn't up. Should we pretend that I was up overnight reading it? I've also worn grey in, because I'm on the Pigeon podcast today. So I've gone a little bit Pigeon theme for you.
Nice.
I just want to mark out two things here. One, which is James commenting that overnight the Lord Darzi report has been written, which, I mean, we knew it was going to be a rush job, but I didn't think it would happen overnight. And also with Liam joining us today, I think, someone will probably correct me on this one, you are our most common recurring guest.
Yeah, I'd agree.
Oh, yeah, I'll take that.
I'd agree. Talking about it being written overnight, you might think that's some sort of slip. However, I'm sure all of us here have written a dissertation at some point in their lives, and I'm sure that was all very much disproportionately weighted towards the night before. So, just saying, I imagine at least some of the work was done last night ahead of this morning, or at least someone was panicking. So
Starmer and West Streeting were like, we cannot accept your report after the 11th of September or something like that.
And if we see you in the student union in the weeks preceding, we won't be happy.
Oh, brilliant. Cool. All right, let's get into it. So, the independent investigation of the National Health Service in England has been written by the Right Honourable Professor the Lord Darzi of Denham, OMKBE, FRS, FM, FMed Sci, on F. I mean, the guy's got more letters after him before his name than in it.
You don't have to fill
it's like the whole of the Wu-Tang Clan after his name, isn't it, really?
Liam, as I say, you've read this. I mean, congratulations for getting through 163 pages, first of all. I did a quick Control and F on technology, and I've read those parts. And I've read your commentary on it. So why don't you just give us a bit of a summary? What did you think? I mean, what was it for, first of all? Why has this been done? After reading it now, why do you think it's been done? What's it saying, and what are your thoughts?
Well, there's a few things. Like, firstly, of course, as the title says, this is a highly independent investigation that has absolutely no political bias in it whatsoever by a sort of well-known Labour supporting Lord, of course. So, although, look, before I get a bit sort of tongue-in-cheek and joke about this, like, I think just to be clear, like the 2008 report, for Lord Darzi and the work that he's done throughout his career is absolutely fantastic. And actually, as a thought leader, he's a wonderful member of the NHS. And I think, had we listened, or had Andrew Lansley listened a little bit more to some of the things that he said, we probably wouldn't have been in as bad a state. And there are a couple of references too that would have been the case in this independent report itself. But a short while ago, obviously, Labour had finished trouncing, or the Conservatives finished trouncing themselves, depending on how you look at it. And they're obviously in the process of doing their victory lap. And look, as we know at the moment, the Labour Party is very much taking a policy position of we're going to really point at everything the Tories have got wrong. And, I don't think that's even contentious now, given it's basically every single response they're making at the dispatch box at the moment. So they got in Lord Darzi to do a very, very rapid investigation around basically what the state of the NHS is in at the moment. I suppose, the pessimist's view is it's not good to read before your bedtime because you're not going to sleep well. The optimist view is that it's going to allow them to be able to justify some things maybe that wasn't promised in their manifesto. And I think, to be honest, everyone's holding their breath and waiting to see whether this is basically a solid beating of the previous administration and that's it, or whether actually it's going to say it's worse than we thought. Although, again, whether is actually whether there's anything here that they couldn't have found out beforehand, but it's worse than we thought, and therefore we're going to need to do a little bit more. So I think we're all waiting to see. And to be honest, I was kind of hoping that there would be a lot more in the report that said that the NHS is significantly underfunded beyond just capital spend. But I think it does indicate around what their policy levers are. So realistically, I think we can probably take it that this review, where Darzi went out, got lots of people to input, lots of charts, spoke to lots of hospital CEOs and patients and stuff like that, and that this is going to be what hopefully sort of dovetails into what the Labour policy then says going forward. And to be honest, I think you'll probably share my sentiment in this, that we all just want to know what's going to happen next, because we're all sitting around waiting to understand, will there be money? What's going to be the priorities? And, this no man's land that we're all in at the moment is not helpful for anybody. So the report's out, it's here. There's a lot of charts talking about basically everything that went wrong between 2010, particularly over the last decade, and that has gone through and just illustrated all of the various issues that have happened. It really goes to town on the Lansley reforms in 2012, 2013, which is understandable, and doesn't go in as hard on the most recent Health and Social Care Act changes that happened a handful of years ago. So I'm not giving you any chance to direct the conversation, asking questions. I'm just basically on a pedestal doing a monologue. I can carry on, or we can go into some specific areas if you'd like. But ultimately, there's a lot of charts saying we're in an absolute dreadful mess. The NHS is, to a certain degree underfunded, that there are, that basically every metric he could find is that we're not doing very well and we need urgent change. So I guess in terms of specifics, I'm aware that for your audience, the biggest area of interest will be around technology and funding and what that's going to mean. So,
well, yeah, let's get into it, man, because I saw your LinkedIn post this morning, and you had an interesting reflection on the way that technology was talked about. Do you want to go through that?
Yeah, sure. So I think, interestingly, in the report, there was sort of an element where it talked about the challenges around capital and also investment in technology. And to be honest, anybody who's ever tried to submit a business case or tried to do any kind of arrangement with the NHS will have come up against this and be quite frustrated that there's two ways that the NHS looks at things in terms of funding. There's capital, which has historically been stuff that you buy, and then there is revenue, where it's basically ongoing costs and ongoing investment. Now, previously, when someone used to buy Microsoft Office, they'd pay once for it, and that would obviously be capital. And yet somehow over the last 15 to 20 years, we still managed to stay stuck in this view that technology is capital. Now, of course, if you're buying a really expensive scanner, that's fine. But the problem is that at the moment, most of the technology narrative is intermingled with capital. And so it kind of says capital investment is really low and challenging. There's a significant underinvestment in technology. It's really important. So we've got to invest more in capital. And I'll be honest, that for me was quite frustrating because and it did talk about the challenges later on of the capital model itself. But the problem here is that for a lot of tech companies, if they're trying to get recurrent, if they're trying to build sustainable businesses to provide valuable products and services to the NHS, and to do, whether this is an EPR, whether this is artificial intelligence, which is referred to a lot in the report, it's not capital funding, because capital funding is an instant one-off spend. And that's not the business model of tech services anymore. And to me, that's really worrying, because it's just kicking that problem down the road, and it's not addressing it, when I can't imagine that wasn't raised to him by people who are involved in putting into the report.
Yeah. And so just to summarize this, I guess for people that might not be so au fait with financial language, if I'm understanding correctly, what you're saying is the way that tech is talked about in this report is it's talked about as a cost. It's talked about as you need to spend money to bring a piece of tech in without regard to that increases productivity, that creates saving, that's more of a line on other things it can do. Or are you just saying that is that what you're sort of saying there?
So a capital so revenue spend tends to be relatively consistent. You raise it and reduce it, right? And so, if you're running a business, you've got your recurring ongoing costs, and then you've got your one-off costs. And technology is still seen as a one-off cost. Now, the business model of every single tech company is nowadays year by year by year by year.
Yes.
So you go in and they go, well, we've got capital, but we can't spend it but your revenue. So what happens, and I think the challenge is that most tech companies which are struggling to get sustainability will go in, they'll accept capital funding. So if you take, for example, in late 2021, there was the Unified Tech Program, right? Or the UTF funding program, which was quite significant. It was all capital. So they wanted to spend it before the end of financial year to get technology in, which is fine if you want to pay to test something. But if you actually want to keep on paying for technology, so right now, if you go to most ICBs, that they're going to be really struggling to justify keeping their ongoing tech spending, even if they might have capital money. And this is it's a really geeky point, but it's super significant because it's about how we think about funding technology in the longer term, which according to the report, we need to lean into it more. If we need to lean into it more, we need to lean into a reasonable way of actually funding it.
So this does explain why it's often talked about that tech companies struggle when they're coming to the end of a contract because there's just no guarantee that anything will get renewed, even if they've delivered really well, because it just gets considered as a completely separate procurement almost, because it's a new pot of money. It's that one spend, and next year it's a different spend and that kind of thing. And it's just not committed to a consistent P&L, I guess.
Like Microsoft Office 2008, or 1998, that's I don't know any tech companies now. Even the device and the hardware companies are generally product and service. There aren't really many valuable tech offerings that are being provided to the NHS that aren't an annual recurring, i.e. revenue spent. And if that's not provided for in technology, then what they do is they buy a bunch of MRI scanners, which will probably have a service cost still that is ongoing. And we won't get investment in things that are more software and platform oriented.
There are a couple of things in your reflection that intrigued you as well as annoyed you. The tech being one of the things that annoyed you. What intrigued you?
So the first thing I think is, and to be honest, this isn't a drum that hasn't been well banged over the last sort of 10, 15 years. It's been said for a while, but I think there was a really, really strong emphasis on not just investing in hospitals, but actually going out into community health services. So generally, most people know about two tiers in care. They kind of know you've got your primary care, your general practice, and then you've got your acute. And then there's community health services. And community health services are one of those that wasn't properly formally defined. It's always kind of been a slightly sort of weird sort of side nugget to care, but actually provides so much of the valuable long-term care for people who are about to maybe go into acute treatment or that we want to stop, and also those who are coming out the other, sort of sliding out the other side of it, particularly when we've been trying to reduce the capacity on this. So a lot of the report, as to be honest, was said in the long-term plan, and as is said in many other areas, a lot of the report, the emphasis on the report is actually we need to stop investing as much and focusing all of our attention on acutes. So it references, for example, virtual wards. Virtual wards was given to hospitals, but actually most of the workload for that kind of went into community, and then it was up to the hospitals to think about how they distribute it. So in terms of this, community health services has got a really good mention. And to be honest, I think that's a really good thing, because actually it's really necessary, because if we're going to, we need a better formalization and understanding, because it's often been the underfunded kind of sector and the misunderstood sector. Most people use community and they think about GPs, but there is this whole other sector that accounts for a third of contacts in the NHS. And that is your community nurses, that can be your school health services, that can be a lot of your physio services that everyone seems to think just exists in PCNs, but your longer term physio, or stroke rehabilitation, or neurological disabilities, or health visitors, they sit within most of this provision. And it may sit within acute, but generally most of this is a separate thing. And so funding for that feels like a really good idea, to be honest.
Nice. So I know you've got to run in a second. They've had a go at the Conservatives. They've laid the ground for some decisions and for some potential changes. What happens next from here? What does this report actually mean? What from here is going to happen?
Well, Labour's saying that they're going to produce a 10-year plan. So I think we can take that this is a bit of a preview of what they're going to kind of cover in their 10-year plan. And, as I said at the beginning, I think we're all waiting to find out exactly what that says.
Is that in anticipation of a second term, or is that to lay the ground for making the next government reverse it to a political backlash?
I I think given the election we've just had, I think the odds are on that Labour's going to be working through 2 terms, and they can think about that. To be honest, doing what they're planning to do, or what we don't know they're planning to do, but what they might be planning to do, like, if they're planning to really turn it around, that's not a 4 to 5 year activity. That's a 10-year activity, right? if it took 10 to 14 years to get us into this mess, it's not going to take 3 to 4 to get us out of it, right? So, I think we're going to see a lot of emphasis on sucking it up and paying, and like, to borrow from what the Health Foundation says, which was quoting Wes Streeting, no investment without major surgery. And I think there's a very clear emphasis on this. So I don't think this report is going to give us a sort of a showering storm of cash that's going to be landing on the NHS, which I think everybody would like. And I think the fact that it was absent from this report kind of says that too. I think the other thing is there was a lot of things in the Hewitt Review, which came last year, which had some very sensible recommendations that have barely been touched upon. I think there's 1 or 2 references in this report, such as why we're working on annual cycles. So if we want to actually prevent stuff, at the moment, with the current financial circumstances in the NHS, every single area is having to think, what can we do in year? Which means they're not thinking about how do we stop something happening in 3 years? Like, most transformation projects take more than a year to really see the results. They often take 6 to 9 months to even get going, so we don't see the results. And that was one of the major things that the Hewitt Review emphasised that is totally missing, which was a real shame. And so I don't think what we're going to see, and I think the other area is, she was saying too many targets, which it is referenced within this report, and also that NHS England kind of needs to get out of the way of ICBs and stop micromanaging them. She may have used that exact word, micromanaging, I don't know, or I may have just taken it from that. But that stuff was absent too. So, or largely absent too, which, to be honest, is slightly concerning, because it kind of sees that we're going to see more top-downery, which I think, from those at the top of the nest, I think all good intentions, but we kind of need, if we want the ICBs to succeed, we need to let them actually do it without tripping them up every 3 to 6 weeks. So we'll see what Labour says, but to me, my concern is it doesn't go far enough, and it won't go far enough if we just read from what's been said in the Darzi review.
So, final question then, for me, then, is just if you look a few years ahead to the next election. Obviously, we're talking. It's interesting to frame it in an election cycle piece. Like, this is a 10-year project. What has to happen by 2029 or whenever it is for them to be able to say we're on the right track and be able to point to stuff?
I think the various targets, waiting lists, like outcomes. So, for example, cardiovascular disease is pointed as one of the examples in the report that has gone in the wrong direction. We were actually in the West, we were doing better, and then it's kind of dipped over the last handful of years. So that's kind of a good example where, with long-term and major conditions, we're not preventing enough, and we're not stopping these things from happening, and they're just growing and growing, which means multimorbidities, which means higher costs, which means all of these different things that relate to the pain in the system. So, to be honest, again, I think it depends on what their vision is. On, I know some of the things that I'd like, that I sat and talked to James about on the Healthtech podcast a couple of months ago, right? But like, in terms of what needs to happen, I think the most interesting thing I heard just before the election was by one of the more political sort of advisory organisations, and what they said is that we'd probably have a fair bit of pain in the first few years, and then there would almost be maybe a political point that the ICB model hasn't succeeded or succeeded enough, and we're going to get like maybe an evolutionary or mini reform to kind of maybe head up to the election. So, because I think realistically, if the NHS isn't performing, they're going to have to find a way to explain why, because most people think that won't think that the NHS turnaround is going to be a 10-year activity. The voter just doesn't have those patience, right? So I think it remains to be seen, but we might see some bigger changes in the second term after I suppose what we can see the current administration in all departments, in all areas of spend, is like, we need to create some pain in order to reverse this situation. So pain, and then maybe more gain in the next term, one would guess. But again, this is all speculation. But we'll get the report soon, like the October, the budgets will tell us a lot. So we don't have too long to wait now, maybe a month or so.
Well, Liam, thanks for joining us. Thanks for reading the report. Any final thoughts before you leave us?
No, I just feel slightly disappointed that I didn't manage to get in as many pigeon puns as I was hoping to. I did promise Huw that I would do lots of pigeon related puns, but
it was
just
a condition
didn't
of
manage
you
to,
coming
so.
on, Liam. So
I know.
There will be no fourth time.
It's a good job I dressed as a pigeon. Otherwise, it would have been a total failure of a guestie, right?
I'm sure we can add a Snapchat filter.
I know. That's why I wouldn't have dressed up for an audio podcast, right?
As I say, we'll get a Snapchat filter on. There used to be one where you could have a pigeon head. So, we'll look into that.
Yeah, I did promise Jess at one of the conferences that I'd happily go dressed as a pigeon to the conference for
that pigeon suit is coming. That pigeon suit is coming.
Yeah. There's
been a line on the SomX P&L for a while that the pigeon's in. It's in our projections.
Yeah, your long-term 10-year plan needs to include a pigeon suit or two, right?
Multiple by that point. Yeah, absolutely.
Yeah.
Liam, absolute pleasure, mate. Thank you.
Is this where I sink down now, yeah?
Exactly.
Right then, here we go. Bye,
Liam. What an exit. Huw, what do you reckon? I mean, Liam's a smart bloke, isn't he? I mean, he knows so much about this stuff. And I sort of, when he feels despondent, I feel despondent. When he feels optimistic, I feel optimistic. I think it was relatively balanced what he was saying, seemingly. And my feeling is like, let's wait for the 10-year plan now. Let's wait for the budget. It's sort of what we were all expecting. They've blamed the Conservatives. They've laid the ground for hard decisions, which are going to come. We'll see, I guess.
This isn't a plan. It's a report. It's a report that says, I mean, you'd have to be politically naive to think it was completely independent and that they were just going, oh, yes, I bet there was some backroom chatting before publication. But I think it addresses challenges that do need to be addressed. It puts some thought into how we actually do adjust spending. I think what Liam was talking about on the capital spend, the one-off spend on tech will be something that pretty much every tech company listening that works with the NHS will recognise in the pilotitis thing. It's one of the biggest challenges of innovation in NHS
really
tech, and I think addressing that challenge could be on its own huge for our sector. I don't know if it would make a massive difference politically down the line, but I think we would see the outcomes and the benefits of it. I think what is an exciting thing for companies, our industry at the moment, is there is a lot up in the air at the moment. There's a lot of recommendations. There's a lot of interesting, beneficial things that are coming their way potentially. And I think now is really the time to get involved and start, if you need to establish your need, if you want to start positing the benefits of particular technologies or particular innovations, or addressing some of the kind of key challenges that the NHS is talking about and that this report has talked about. Liam talked about the cardiovascular piece, and I think some of the outcomes around these are going to be big priorities. So if you're working in this space, or you are tangentially involved in this space, or you have something to say, start saying it and start talking about it and start having discussions with the people that matter. And it's part of, I guess, running a health tech business, or any business, is that you can talk to the procurement team or the buyer in your hospital, but if you're talking at a high level, getting your opinions and thoughts and arguments in front of people that I guess in different rooms, different spaces, different areas, that's something you should be doing.
I think that's a really important thing to say. You and I were both on a kickoff call with a new client yesterday on the SomX side, and we talked about lobbying, didn't we? We talked about actually how we asked the question, what do the perfect conditions look like in order for this to scale? What needs to happen? And the answer was a fundamental understanding of X problem across the system. And it's really interesting timing, because I'd actually just listened back to my podcast that I did with Malta from the Health Foundation. That was all about the power of policy in health tech. And I've put an article up on the SomX Academy on our website about this, kind of summarizing what I think were the learning points for founders. But one of them was, as a founder of a health tech company, you can affect policy. you can affect change. A policy change that happens can completely fertilize the ground for new innovation. And the example that I used with what Malta and I talked about was just, again, like another overnight policy change of GP practices need around-the-clock triage ability. All of a sudden, that just enables a load of AI triage companies and capabilities and all the rest of it. And so there are these policy changes that even as a founder, that founder that we spoke to yesterday had written to NICE and explained, here's all the evidence for this, and here's why this should happen. And these are all steps along creating the change that's needed. And it probably escapes a lot of people, actually, that policy's a lot more influential than you think. It's a lot closer to you than you think, and that even as a health tech founder or as just someone who really cares, you can look at organizations like NICE and you can find out how to write to them and what you do need to say to them in order to affect change. And as part of all of these consultations and things, you can get involved. And these reports being written, you can find a way to get on the radar of the people writing them in order to be interviewed and all these things. And yeah, I think it's just a really important point.
And from that AI triage piece, I think it's a really good area to point out that nothing is easy. There will always be dissenting voices on each side. There are challenges. An AI triage issue presents a huge problem for the people who have to man the triage and what happens to those requests and things like that. So, mandating that would definitely improve conditions for AI triage teams. It's a bigger challenge when it comes to funding and addressing, and the admin challenge and the clinical challenge that comes with that. But the importance of lobbying and getting your opinions out and pushing into that is that you can start to form those coalitions of compromise. You can start to form the understandings of what has to happen, how you adjust one way of doing things to meet another, where the funding needs to come from certain places. What are the compromises? I think a lot of the problems we are finding is that there aren't any compromises being made, and particularly, I don't necessarily think it's a last 14 years of government thing. I think it is just a challenge that discourse has become an issue where everyone it's become very zero sum in how we lobby and argue for things in a game that simply cannot be approached that way. So, just getting involved in these discussions, starting to have these conversations with the policymakers that matter, the other sides of the conversation, and starting to form a consensus on how we need to approach what, very basically, from a purely hypothetical principle, it might not be that AI triage is 24 hours. It might be that it's 7 till 10. But, it's about addressing where can we find funding, where can we find the balance in what needs to happen, where can we find where does technology sit alongside other factors. And I think it's really important for tech companies to be part of those conversations, whether that's on a one-to-one level when you're going through innovative access pathways. I think the work the MHRA are doing is very interesting, or whether it's joining groups like Tech UK's health division or the ABHI in terms of the influence that they are having in these conversations and being a part of that and help shaping the overall policy. Even from a broader tech, there's organizations like Codec who are lobbying for startup conditions. And they're called something else now. I apologize for them. Yeah, Startup Coalition, that's it. But you see where I go. It's just get involved, be part of the conversation. If you see something and you think this doesn't work for me, probably doesn't work for other people, start talking about it.
Definitely. I think that's one thing that I will say about entrepreneurs is that they are the people that don't just listen to the problems and recycle the problems. Those are the people that do actually then go, well, how do I actually change this? And so, I think that the value of raising it now is I think to enable those of you that are listening, that are get up and doers and do get frustrated when problems are just talked about. Policy is a fantastic place to actually divert some of your attention because you can affect change more than you might think. So there you have it. Lord Darzi report's out, 163 pages. On 130 something is when the conclusion starts. Probably recommend you start there. It's quite a good conclusion. And if you want to go a bit more in depth, Control and F for technology, and then that'll show you the bits that are interesting to us. So give that a read. We'll move on. Our second story this week, the NHS has been warned on a potential rollout of AI-powered genomic health prediction. So I've had a little read and I've gone a little dig on a few articles about this. So to cut a long story short, there's been a report from the Ada Lovelace Institute and the Nuffield Council on bioethics. And they have warned against a potential mass rollout of AI-powered genomic health prediction. So let me explain what this is. AI-powered genomic health prediction is essentially, imagine a world where everyone got a genomic test, and I mean everyone. Every single person in the country got a genomic test. And then what you did was you inferred a load of potential health risks to those individuals and those groups. And then you reorganized healthcare in lieu of what you've just found out. That's a potential world that we could live in. And what this report from the Ada Lovelace Institute and the Nuffield Council on Bioethics have done is they've looked at that and gone, I mean, again, sounds a bit Ministry of the Obvious, but that could pose risks. I mean, it definitely does pose risk around privacy, discrimination, and societal problems. It recommends that policymakers focus on enabling targeted deployments of genomic health prediction within a very, very strong regulatory framework. Now, the reason that I want to raise this on the Pigeon podcast today is because I've been talking recently quite a lot about the ethics of AI and quite a lot about where we should be placing it and where we shouldn't. And I've been saying that broadly we're sort of directionless on where we want AI because we're seeing it being piloted and tried and tested and developed in absolutely all corners of healthcare. What I absolutely love is that there are these two groups of people, at the very least, thinking really deeply about this stuff and at least placing a marker in the sand and warning against a really kind of dystopian world where everyone in the country gets AI-powered genomic health prediction. I absolutely love that they've come out and gone, that is a world that we just do not want to live in for all of these reasons. And just to raise a few of the points, so they've said there are risks and concerns not only relating to that, but even just the uncertainty about the effectiveness of the technology right now as well. So is it accurate enough? Can we actually trust all of that stuff enough in order to take action at some relatively large scale? And they've really lent into this concept of we don't want to rubbish this completely. And they've really gone strong on if it's targeted extremely well within a really strong regulatory framework to protect against privacy risks, use of sensitive personal data on mass scale, genetic discrimination, particularly in the context of things like health insurance. If it's used in a really targeted way amidst the framework that protects against that stuff, it can actually be really, really useful. So I love this. I think this is great. More of this, please, because I think this is taking a really fuzzy and foggy future around AI and actually just adding some focus, which I really like. So well done, the Ada Lovelace Institute, and well done, the Nuffield Council on Bioethics. You have a new fan.
Yeah, I've got to agree. And I think if you're still listening to this podcast after we've been banging on about the NHS and you're not, active in the UK system or that interested in the NHS, first of all, well done for staying to this point. But second, this is recommendations to the NHS and the UK system on the use of AI-powered genomic health testing. It really is, but it's so applicable beyond that. It's applicable to across healthcare. Like US systems should be taking these kinds of recommendations in as well because it's so important. I think what's really exciting about this report and why it comes now is because I think, in the context of human genetic testing and, the idea of genetic discrimination, all of these things are very interesting, but it's been more than 20 years since we first sequenced the human genome. And way back then, it was a massive success. We've successfully sequenced the human genome. We understand how to get people in, sequence DNA, sequence their entire genetic structure. Understand that and there's been lots of, oh wow, this is fantastic. What could we do with it? And I think for at least a quite significant period of time, we're talking at least a decade, if not more, after that happened, there was a slight flop. Basically, a slight disappointment there because we'd done it and it was too expensive to do it regularly. It was too difficult to do it regularly. It became the kind of like, oh, let's get, if you want to spend thousands and thousands of pounds, you can have your own genome sequenced and find and understand what that could mean for your genetic profile and your future health. And of course, by and large, people didn't really want that because ultimately, what could they do with that information? Like, do you personally need to know that you will develop Alzheimer's or that you have a higher risk for Huntington's disease when there are things that, for example, there is no cure for or there is no effective treatment for, and that you can't really start being cared for until you start developing it? Do you need to know that? So, on that, it's been a bit of a basically. I mean, that's the only way I can say. As that process has become cheaper and as AI has come into hand and as preventative medicine starts being far more interesting, far more the push, the focus, the challenge is how do we address that preventative medicine challenge? Genomic testing's come into its own, hasn't it? It's think about the potential. There's so much more we could do now than we could do when we first did it, and we're all really excited about it. So it's wonderful to see. Obviously, since that first time it happened, though, and we determined this, immediately the first thing that a lot of people leapt to in the US, the UK, wherever we were talking about it, that irrelevant of your health system was, this information, what personally you could develop from your own personal genetic testing. Your insurer is going to use that against you. That's going to cost you more. If there's a higher chance based on your genetic testing that you are likely to develop all of these things, this is a really big problem. And that's been a point of conversation for a while. And I think there have been definitely attempts to kind of prevent that from happening in terms of I think in this report they call it genetic discrimination by your insurer. And I think that's a very interesting point. This report's so great because it addresses the kind of challenges and the importance of doing something about using it on a mass scale. And I think that's really interesting. Ironically, though, the challenges are still about how it's used on a personal way to get the most out of it. It's talking about consent. It's talking about considering that data to be personal data. And that's really important. I think it's probably an easier conversation to have in the US, where HIPAA is very, very strict on what health data is and the control of it, and it's regulated harder than personal data in the UK. Even HIPAA is such strict regulation on the use of health data that I think this is more that question is more of a focus for us. I do think it's very interesting to talk about models of consent with how we use and share personal genomic data, because there's a story that's not in Pigeon this week because it just feels like a follow-up, but it is very interesting. Recently, the FDP is being challenged by lawyers who claim that the model of data collection, where pretty much everyone's data can be used on the FDP, is probably illegal. And patients, they may have to adjust the legislation around it or the policy around it to ensure that people can opt out. And I think it's important while we're having discussions about genomic data to look at how we're already having those discussions about just regular personal health data in the UK. Do we have a model of consent that meets this? Is it clear enough where your data is going? Who will access your data, your health data, when you go to hospital, when you go to your GP, when you go anywhere else? who has access to it, who is using it, and what are they using it for. I don't think it's necessarily a problem, but these recommendations, the understanding of what consent and the granular consent around both genomic data and health data is a really big question. I think parties are going to have to answer from just a personal data level before we even get to the genomic piece.
I think that's awesome, Huw. And I think I'll just end by a quote from the chair of the Nuffield Council on Bioethics, who clearly agrees with you. She basically says AI-powered genomic health prediction has the potential to offer us a lot, but this report clearly highlights that we're not ready to fully embrace it, nor is it ready to deliver on its promises. We must now take a step back, engage the public fully so that we can ensure the use of it in our NHS is not only wanted, but also trusted. Only by embedding ethical considerations from the outset will it reach its full potential. So there you have it. I think we're all in agreement. Not there yet to be used on a mass scale. Plenty of conversations to be had on the individual level and on the system level too.
I have one final, just interesting, to me at least, thought on that. And I think one of the things this stresses is the idea of public engagement around use of data and use of genomic data as part of this, and in any future use of AI-powered genomic health prediction, etc. Is that, and it links us back to the FDP, where I think back in, it all went through. The government pushed the FDP into use, and absolutely Labour's got behind the FDP as well. There's no political issue here. Though there are significant challenges.
Just for people that might not know, Huw, just explain what the FDP is quickly.
So a federated data platform, very briefly, is essentially a unified federal use of people's health data across the US so that it can be used for, easier movement of data, but also easier use of data for research and population health. It doesn't apply to primary care yet. It could in the future. But health data from secondary care, acute care, all other, a number of, frankly, wide varied range of where your health data is stored is being moved by trusts into a federated data platform. There has been heavy resistance, both from civil society that thinks it's taking this consent model, this kind of challenge around consent, away from people who don't really have an option to opt out of their data going onto this platform, but also from trusts who may have had their own variations of it or versions of it, or shared consortia across the NHS who had their own data linking platform, and this is replacing. Some don't think it's as good, some are fine with it. There's been a big challenge and a big call for public engagement about how it's used, and in fact, once it was finally, pushed through and became a feature that will eventually hit every NHS trust. Every NHS trust will have to, and there is a deadline for them all to start adopting and using the federated data platform, which was itself a reversal on a previous decision where they said it will be, an optional movement towards it, and ideally we'd get everyone engaged with it. One of the things that's been, missing from that conversation over the last year is that there was the call for public engagement around it to understand, how do we make people understand how their data is being used, understand what the FDP is, and push the benefits of it. No, there are a lot of benefits of it. There are some negatives about it, but there are a lot of benefits. I've not seen anything at all off that project of work. And there was a significant consultancy budget that went into running that public engagement process to inform the public on their data. Now, I think this ties into our conversation on the Ada Lovelace piece and the genomic data testing piece. And I think that quote from their chair is a very interesting one, because, we need to step back. We need to not move too far until we've engaged the public. I want to see what these processes look like. And I'm not saying they don't happen. I just wonder if they're happening on an engaged enough scale. What does engaging the public mean? Is it just, the high engagement PPG groups? Is it, round tables? PPIE groups? Is it round tables with, representatives of local patient bodies? What is that? And how do we take it from there to really informing people on what these things are about and what the impacts and potential and the model of consent should look like.
And very practically building the trust that will lead potentially to a bigger deployment of this, or an actual deployment of this, or whatever the conclusion is. That trust bit is the gap. And so you're absolutely right. That public consultation has to be incredibly practical to achieve that as well. It has to be done. It has to be done very well. And it has to be done so that it can be used as a proxy for what we believe is public trust, and therefore the action can be taken. You don't want to have to go through all of that and then think, oh, we're still actually not sure. So yeah, very important. All right, and finally, scientists have developed, according to this headline, a stunning AI to predict blood pressure from voice. New technology has analysed vocal biomarkers, achieving up to 84% accuracy for women and 77% for men in detecting high blood pressure. Research at Click Labs, with 2 Ks, have made a groundbreaking discovery in health monitoring. They've developed this new non-invasive technique that predicts hypertension just using a person's voice. Innovative method, glimpse into the future. Blah, 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 blah. Obviously, as a clinician, my first instinct here is what a load of nonsense. However, it is, and where on earth, when would this ever be used at a point where you can't just stick a cuff on someone's arm, and what's the use in that? Actually, when I then sit and think about it, of course, this has a lot of different benefits if indeed it works, because if you are monitoring someone's voice in a load of different contexts, whether that's, I don't know, like just a remote primary care, whether that's in an acute 999 phone call setting or whatever it is, it has a lot of it has potentially a lot of benefits. I think what was interesting when I dug into this, I've had a look at the studies, the stuff from Mayo Clinic. There was essentially a big study done that was looking at acoustic analysis and the prediction of type 2 diabetes using smartphone recorded voice segments. And, you know, these are pretty good studies. There's definite evidence that this sort of stuff can be used. So looking at, specifically diabetes here, a recent study assessing vocal changes in cystic fibrosis related diabetes analyzed 7 different features of voice, looked at fundamental frequency variation, what they call jitter, what they call shimmer, noise to harmonic ratio, voice turbulence index, and relative average perturbation, RAP. They've then used logistic regression, native Bayes, support vector machine, decision tree, random forest models, all of this stuff from a technology perspective as well. And what they found was, you can predict diabetes, you can accurately predict someone's blood pressure as well. And so what they basically say is that these things can be used as effective triage. They're not saying that you can get a literal 100% accurate reading, but what they are saying is that these things can be used in triage. I think it's really interesting. I really do. Why the hell not, frankly? Like, why the hell not? Like, this is the sort of thing where almost in the more artistic version of innovation, where you just have a play with things and explore things and the use case will demonstrate itself later. This sort of falls into that bracket for me. There are some use cases that are mentioned when you go digging into all of this stuff that are quite specific, but this is one of those things where I just think we are creating so much data by just speaking into the air. Why shouldn't we be collecting it? Why shouldn't we be predicting with it? Why shouldn't we at least do the science to figure out how that might be done? Because then in 100, 200, 500, 1,000 years' time, healthcare is going to look so different. I think we are going to look back to just think, how much data did we just leave on the table and in fresh air, and that was just disappearing into nothing. So you know what? We have the data, we have the technology. I just think, why the hell not? Let's see if we can figure this stuff out and make it accurate and start helping people with it in some way. I might talk to the fact that we've only got 2 minutes left on the Pigeon podcast, but I just think, why the hell not?
Yeah, I mean, my initial read on this was like, okay, yeah, fine, cool. When would I use this? What's the point? Where is this going to have its most value? And I think, I still have that in a little bit, but I think if you take the Steven Spielberg Minority Report approach and just envision a future that works in the use cases, I think it could be really interesting that you get off a phone call with a friend or family member, and your phone pops up with an alert that says, "Oh, you've got." You're showing indications of high blood pressure and hypertension. You should check in with a physician. All of that. I think, there are so many potential use cases for this, and I think it is very interesting. I wonder if clinicians would be, how far clinicians, like thinking about it from a primary care point of view, would lean into some of this, whether, how does it help? But equally, I think there is the use case where you get off the phone with a member of your family, and it says you're showing signs of high blood pressure, and you think, well, no shit. I've just been asked to come around middle of the evening in the week to sort something out. So of course you're experiencing high blood pressure. Is it predicting hypertension? I don't know. But I think, there's definite use cases and definite potential for this. I think we're probably looking a bit further into the future than the typical innovation, and it's on the interesting engineering, and it's a study. There is definitely real thought and real design process that just knowing this is possible can inform and help inform. It's just looking at the use cases, looking at the design, looking at the user need, and working out how do we deploy this as effectively as possible.
I agree. And I can just think in my mind, if I've got a hypertensive parent that is, losing functions of daily living, and, I know that they ring me every morning and they're meant to record their blood pressure every day on their home monitor, but I'm not convinced they do because they can't be bothered. And just a little warning there. But also just the thing is that I don't think that, and they talk about this actually when you go digging into this, that I don't think people are expecting this to be used in isolation. It's just one of those things that's amidst all the other things that are being monitored. It's just another thing that can confirm or deny something, or at least give you more or less confidence in something if this either points to it or doesn't, as opposed to everything else or with everything else. So I just think, why not? Just get involved.
We're going to need to deploy it before we stop using phones entirely, though, because millennials
Indeed.
already quite poor. Gen Z, not going to happen. Gen Alpha, whatever.
Well, that's been the Pigeon Podcast, everybody. Covered mainly the Lord Darzi thing, a bit of a future, a dystopian future of genetic discrimination. And predicting blood pressure on voice. If you want to get the links to all of those stories and a load more stuff, you can head to the newsletter that comes in your inbox every Sunday. So head to healthtechpigeon.com. For everybody else, thanks for listening, and we'll see you next week.